Hello. Hello. Hello.
Yes, ma'am. The audio is audible.
Okay. So can you hear me?
Yes, ma'am.
Okay, great. So should I share my screen now?
Yes, ma'am.
Okay. It's saying host disabled participants screen sharing. I can see two Ved Kulkarni. So should I delete one?
No, not necessarily, ma'am. The one which you are using now, you can go to the below screen. There's written share screen in the center of it.
Yeah, I did that. One sec.
Okay.
Hello.
Okay. Let me see.
I've just messaged you the window that I'm seeing. And secondly, what is happening is I'm able to listen to my own voice.
Okay, I think maybe it's because, but now the one has been disabled.
Sorry?
Let's see. Can you please try again, ma'am?
Hello. No, I'm still listening my own voice. Should I try to join again?
Yes, ma'am. Please do.
Okay. Hello.
Yes, ma'am. Please try screen sharing.
Yes, yes. Now the audio is better.
Yeah.
1 second.
Yes, ma'am. Your screen is visible now, actually.
Yeah, but then I'm not able to find the PPT where it is one.
I think you'll have to minimize the Explorer.
Okay, 1 second. So this is what is seen right now.
Yes, ma'am.
Okay. Hello.
Yes, ma'am.
Acha. Okay.
Please double click the presentation, ma'am.
Okay, okay, fine. You did it over just now?
No, nothing like that.
How did it open? Okay, 1 sec. Yeah. Yeah. Can you see now?
Yes, ma'am. It's
Okay,
clear.
great. Should we start?
Yes, ma'am. I'll start.
Okay. So yeah, you want to start or I should start?
Okay, I'll do an introduction, ma'am.
Okay, okay, fine. I'll wait.
Okay, ma'am. Thank you. So good evening, everyone. Sorry for the delay. Respected Dr. Radhika ma'am, members of the Safe Dental Updates, and dear doctors. We welcome you all for our 30th Learn from Our Master series organized by Safe Dental Updates. And it's always an honor to be here. So firstly, we would like to introduce ourselves. We are Safe Dental Updates, a dental platform in which we believe quality education ensures predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professionals and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is endodontic mishaps, what, where, and why, given by Dr. Radhika ma'am. To speak a few words about her, Dr. Radhika ma'am completed her MDS in conservative dentistry and endodontics and is currently a professor in D.Y. Patil Dental College. Ma'am have conducted many lectures in Indian Dental Association and published various articles in national journals. She's been practicing as a micro-endodontist in which her interest is towards separated file retrieval, RCTs, perforation repair, endosurgeries, etc. So without wasting more time, I would like to invite Dr. Radhika ma'am for today's discussion. Ma'am, please.
Yeah, thank you so much. So a very good evening to one and all. I welcome all the participants. Am I audible, Dr. Shanu?
Yes, ma'am.
Okay. So thank you for the overwhelming introduction, Dr. Shanuf. I'm really thankful to you all, to Dr. Shibu, for giving me this platform and giving me this opportunity to interact with the dentists who are placed all over the nation. I would like to share my cases and my experience with you all through this media. So to start with, endo mishaps are unfortunate mistakes that occur during the treatment or diagnosis of the root canal. They can occur due to lack of knowledge, carelessness, unforeseen and unpredictable circumstances that are encountered during the procedure. Now, the picture that you all can see here, we never would want this scenario in our clinical practice. The moment this happens in our clinical practice, I'm sure that everyone misses a heartbeat. So what, why, where, how did things go wrong? So let us go step by step and evaluate and try and avoid doing endodontic mishaps. Mistakes are painful when they happen, but years later, a collection of mistakes is what we call an experience, which leads to success. To keep on repeating the mistakes is the most, what you can say, the most wrong thing that we can do in our clinical practice. So we have to keep on learning through our mistakes to reach the goal. Now, sometimes things have to go wrong in order to go right. We go out for a long drive and sometimes the Google lady misguides us and we miss out the turn. But we take a road where we see a beautiful rainbow, multicolored rainbow, and it makes our day. So it's okay if we go wrong, we are going to find something right on that way. So when things go wrong, take a deep breath. Don't push yourself. Just close the case for that particular day. You're already stressed out, you're in strain. So do not force yourself and create more mishaps on the same particular day. So wait for a while, take a deep breath. Just say, okay, it was a bad day, and give a close dressing. When some things go wrong, take a moment and be thankful for something that has gone right. Now, this was the case in our clinic itself, in my early days of practice, where I separated an instrument at this point. But since we had completed the BMP and good cleaning and shaping was done. This was exactly at the periapical area, and we then did not bother to remove this instrument, nor did we try to bypass it. The patient is fit and fine and happy for the past 5 to 6 years, and we have a good follow-up with the same case. So we need to give a thought of what to do when. So why these things happen? So the first and the foremost thing that I would like to convey to you all is always take a pre-operative radiograph. Anatomy plays a major role in having a good, successful root canal. So what happens if you don't take a pre-operative radiograph? Now, in this case, what we can see here, all of a sudden, the pulp has concluded over here. So there has to be some different anatomy beyond this middle third of the premolar. So when we take a radiograph with different angulations, we see a bifid root. Now, if we do not have a preoperative radiograph, we are not aware of what is left ahead of us. So when we take a preoperative radiograph, your mindset has already sensed some kind of a danger which is there ahead. If it is a straight root, no problem. But if at all there is a curvature, if at all there is a bifid root, if at all there is a pulp stone, then you are already prepared for that major hindrance which is going to come ahead. Now, in this case, a preoperative radiograph, this was the case which was sent to us without a temporary filling or whatever. So this was it. So we took a preoperative radiograph which showed us radix entomolaris. So I was prepared that there are two roots distally, but what the radiograph showed me was this as well. So taking a preoperative radiograph is mandatory so that nobody points out a finger at you later on once you've started with it. So you have it for your record as well, that this case already had a separated instrument in the mesial roots. So we went about by bypassing this instrument and completing the case. Now, this premolar shows a bifid root. So the doctor took a preoperative radiograph and she was prepared for a two-root case. But the patient still was in pain after doing the BMP of these two roots as well. So the case was referred to me, and under the microscope, what we found were 3 roots or 3 canals. The patient then was pain-free, but till then, the digging was already done. So we had to place MTA, reinforce the furcation area, and then complete the case. Okay, so this was another case, lower 8, always a tricky root. So always a preoperative radiograph is mandatory because this is the root which is seen. It's not very visible. It is always a 2D image of a 3D object. So you need to be prepared that there is something more to this. So what we need to do is to evaluate this. So do not be in a hurry to go beyond that curvature without good opening of the orifice. So the curvature was almost 90 degrees, which was negotiated, but the radiograph did not exactly give us an idea. So be slow and steady and then evaluate. So just to summarize what we've seen up till now, how to read a tooth clinically and through preoperative radiograph. Now, it can be a rotated tooth, which is seen clinically. So you be prepared that it is a rotated tooth and my axis is going to be along its long axis. So if it is a lower premolar or a tilted premolar or upper molar, which is rotated, so my canal position is going to be say buccal to palatal, palatal to buccal, or if it is a lower tooth, it can be mesial to distal, distal to mesial. So if at all it is a rotated tooth, there is no point finding 2 canals which might be mesially towards the distal side. So we need to be prepared that this is the rotated tooth. If at all it is a tilted tooth, like a lower premolar, so in such cases, my straight line axis has to be parallel to the long axis of the root. If I go straight down, I'm going to perforate either the buccal or the lingual plate. So we need to be prepared by seeing it clinically and a preoperative radiograph, as I have already mentioned. Then a crown tooth. Now, most of the times when we get a re-RC case, the patient comes to us with a crown. So the patient might have gone for a zirconia or an Emax crown, and he doesn't want to replace the crown because he's already paid a bomb for it. So we need to take an access through the crown and do a re-RC. Now, this is actually a tough time for an endodontist to do a re-RC through the crown because the access gets limited over there. So to know the tooth, to know the roots, to take different angulations, help to do a re-RC through a crowned tooth. Then calcified chambers. Now, calcified chambers, we need to read in a radiograph to see that the pulpal chamber is calcified. So when we do an access opening, we are not going to get a drop that we normally get when there is no pulp canal, no pulpal stone. So we need to be prepared that we are not going to get a drop. The drop maybe that we would get would directly go till the furcation if we keep on waiting for it. So by reading a radiograph, we would know that we have to reach only till the chamber without the drop. Okay. Then anatomy of the roots, as I mentioned, or as I've already spoken about it, and furcation. So let us divide this into different parts of the root canal procedure. So I have divided it into access opening, BMP, obturation, and post-endodontic filling. To start with access opening, so the basic thing that is needed for an access opening is good armamentarium. You need good mirrors, air rotors, long shank burrs are available like Mueller's and Ellen burrs for calcified canals. You have DG16 to check for the orifices. You have short shank burrs for the posterior teeth. For advanced levels to remove the stone, we have ultrasonics. We can do it under magnification or micro openers or through loops. So what is a good access opening? Access opening, it is the cavity that we prepare so that it takes in the file without touching the adjacent walls of the tooth. It takes proper irrigating solution till the apical end of the root, and it takes the good obturating material till the apical end of the root. So de-roofing of the pulp chamber is very important to see if there is no missed canal. Most of the times, if we do not remove the pulp stone, there lies the underlying pulpal tissue, which again can cause sensitivity. So all these things are taken care of during access opening of the tooth. Removal of caries is an important thing which is normally overlooked. So removal of caries is the important step because that is the thing that will exactly let you know whether the tooth is going to sustain the further treatment. If it goes for root caries, if we keep on doing a good root canal, but if later on when you take a radiograph and you see root caries, it is of no use. The whole treatment has gone in vain because that tooth is not going to take the crown margin or the ferrule below the caries level. So we need to evaluate after removing the caries as well. As mentioned by Krasner and Runkaus, there are many laws like law of concentricity, symmetry, CEJ, color change. So this color change I'll specifically talk about when you do an access opening. Your enamel is white, dentine is yellow, the floor is gray, the root canal orifice is dark gray or black, and the pulp stone is pearly white. So we need to distinguish under, once we've done the access opening, these different structures on the floor of the chamber. We need to conserve the tooth structure. So doing an access opening doesn't mean that you keep on cutting the tooth structure. So we need to conserve the tooth structure, give a straight line access, look for missed canals. The problem that can come in access opening, as I've mentioned earlier, is access cavity perforation, crown perforation, and furcal perforation. So a good access cavity is what is a straight line access. So when I say a straight line access, my file should go in the orifice without touching the walls of the chamber. So my file has to be dangling in the orifice. My initial smaller files are not going to make much of a difference, but as I go towards my larger files or the rotary files, they are going to bind immaturely towards the wall if it is not a straight line access. And then the tension is created over the walls and the separation happens in the canal. So a straight line access is mandatory. But this was one case which we had come to us. If we can see, this is what we call as a straight line axis, wherein my axis is pretty good towards the distal. But mesially, since the axis was restricted, there were two separations in the mesial canal. I'll come back to this case. This was an interesting case. So another case is this. Now this tooth, upper molar, otherwise there is no reason for a file to separate in the palatal canal. This is absolutely an unwanted separation in the palatal canal. But if the dentist would have read this tooth before, the access cavity is already very narrow here. It's much better here. But this narrow portion, the file which was introduced in the palatal canal bound over here and has separated over here. My mesial and the mesiobuccal and the distal roots are very much thin and calcified. So the dentist, he ideally should have been prepared for a thin canal and without forcing the file, making a good access cavity preparation. So a missed canal. Now this is like a vicious circle. If you do not have a good access cavity, you miss out on a canal. If you have a thin, a small, tiny access cavity, you do not see or do not find an orifice as the canal was missed here. But again, the lamina dura would help you. The angulation of the radiograph would help you to detect the extra canal or the bifid canal. Now here this case was referred to find out a distal canal in this. The dentist had missed out on a distal canal. So the reason was that the access was restricted. Now the canal is here. If I try to find out here, I'm not going to find the canal. So slightly extending the access. See, access cavity, making it a good access cavity doesn't mean that you keep on chopping off the tooth structure, but at least the amount of removal of enamel and dentin is needed to see and access the orifice. Okay. Then a missed canal. Here the patient had complained of pain in this premolar. It showed lesion periapically. So a change of angulation gave us an extra canal. Access cavity or crown perforation. This was a very interesting case. This patient had come to us with this kind of a perforation. Now, nobody can actually think of that how this perforation has happened. How can the dentist go from this area and perforate it over here? Can you appreciate the shadow of the burr? A long tapered burr, which has been introduced from the distal side. So these things, I mean, here we actually didn't have any answer. I'll come to this case as well. We tried to save this tooth. The patient is as of now okay with this, but it has been told to the patient that it might go for extraction. This was another very interesting case wherein the patient was happily eating from this side, but then after a few years, she got an abscess buccally. So that was the reason she came to us. On taking a radiograph, what we saw was something like this. It was nothing less than an, I would say, an agarbatti stand, where there has been piercing all over the root. So I'll come to this case later as well. Then was this access opening, missing out on the long axis of the tooth and creating a new foramen. Then was this furcation. Now, in the bargain of finding the canals, you cannot compromise the furcation. Okay, so maybe here there was a pulpal stone because of which the dentist did not get a drop and kept on going till the furcation area. So here we are compromising on the strength of the tooth. So whenever I say that we have to have a good access opening, that doesn't mean that we compromise the tooth at the furcation area. So here we had to reinforce it with MTA. So this was case which I was talking about. We had to do a hemisection. We did a RC and we did RC for this distal root as well. Placed a post over there and gave a bridge to the patient. But again, these things need a follow-up to see how they have stayed. Then root perforation. Now here, the canal hardly shows any pulp. So while doing an access opening, we do not have to go that much deep that your file will easily go through the lateral walls of the root. The second X-ray shows us resorption. So again, the perforation through this area reduces the prognosis, good prognosis of the tooth. Just 1 second. Yeah. Then in such cases wherein the transportation has already occurred, it is very difficult to negotiate the canal and come down to the apex. So this is as good as a new canal or new foramen which has formed, and we need to treat this and pray God that there is no formation of the lesion in the periopical area. In such cases, the only treatment that we are left about after, say, a good follow-up, and if at all the lesion develops, is apicectomy. So ideally, to follow the long axis of the root and axis opening without any hindrance over here is mandatory. This was another case wherein the lateral wall of the root was compromised. On taking an angulated X-ray, it showed the lateral wall of the root was completely, what you can say, there was a perforation through the lateral root or lateral wall of the root. So we reinforced MTA and we did an obturation over there and the patient was fine. So coming to glide path and pre-curving of the instrument. So how can we avoid doing a transportation or over instrumentation or any kind of a mishap? So the first and the foremost thing after doing an access opening is to check for a glide path. Never ever be in a hurry to take your file and try to reach the apex. You do not get any award for reaching the apex, but that itself creates a hindrance, because sometimes when we say that I had just put my first file and then there is a ledge. Yeah, that first file itself has made a ledge, because you did not pre-curve it, because you did not read the anatomy of the tooth, because you forced your file inside. So that was the reason you have created a hindrance over there. So in this case, when you see this X-ray, what is a glide path? When you open the, when you've done the access opening, you take your file, 10 number file, and passively tap it in the orifice. May it go 10 mm, may it go 15 mm, that will actually tell you how the tooth is. It will exactly tell you how the anatomy of the root is. So if your file goes easily, say around 20 mm, you should be happy. Celebrate that the canal is straight and nice. But if it goes, say, 10 mm, then you shouldn't be pushing it. Now, when such situation arises, you go 10 mm with your 10 number file, you go to 15 number file, that will go, say, around 5 mm. You again go back to your 10 number file. So now this 10 number file will go 12 mm. You go back to your 15 number file, now that will go, say, 6 mm. So slowly you're opening the orifice. Such cases, we directly do not use an orifice opener, because even that can create a ledge. Using a piezo or a GG or an orifice opener, in cases where the curvature has immediately started from the middle third, will definitely create a ledge in this middle third area. So do not be in a hurry. Only the hand files, that is key files, will help you to negotiate and go through this curvature. So go back to number 15, again go back to 10. Now your 10 will go, say, around 18 mm. Then you go back to 15, that will now go 8 mm. So slowly what you're doing is you're preparing the path for your 10 number file to go till the apex. Do not be in a hurry. Apex locators are there to help you to know how much short you are. So always go step by step. Now, these are the stoppers which will help you in curved canals to show you the direction in which you had put the file. So you can place the pointer of this stopper accordingly. When you place the file, slowly rotate the file so that it goes into the curvature. Always inspect the file. Do not blindly pick up a file from your box and put it in the canal. So what happens is, whenever there is a calcified canal or whenever there is a pulpy stone, this kind of your kinked area, it gets stuck in that region. And when you pull it out, this part separates in the canal. So it is not necessary that every time your rotary file or your larger taper files will get separated. Even your 20 number or your 15 number, if forced, and if the file has got a kink, it can always separate in the canal. So be very careful while picking up a file. Now, coming to a very important thing, which is most of the times overlooked, the working length. Now, working length, we have different gadgets or different methods of checking working length, like apex locators and radiographs, tactile sensation, paper point, patient's response. So there are many things, but at the end of it, why does it change? Most of the times we say that my initial working length was so and so, but my GP point didn't go till the apex. So why did that happen? So one solution to that is to check for the patency, to check for the reference point that we have taken. Now, this reference point, how does it change? When we take the reference point, and then when we do the relieving of traumatic bite, the reference point changes. So in the first picture, this is the cusp where we have taken the reference point, and then after doing the access opening, we have trimmed this so that there is no traumatic bite, and then the working length changes. So my advice is, when we do an access opening, right in the first sitting, before we take the working length, we need to trim, we need to place the articulating paper and check for the high points, and then trim those high points so that once we have taken the working length, my reference point doesn't change. Most of the times you can also write down in your case paper which reference point, which cusp, because if my file is going tilted in different direction, then my reference point is my opposite cusp. So not every time my reference point is going to be the same cusp. So always note down where you've taken the reference point so that your working length doesn't change. If it is an apex locator, you can keep on taking the working length, but if you all are taking through a radiograph, then it is mandatory. You can't keep on taking the radiographs. And if the working length changes, every time you do a BMP, your working length is going to change. So the working length also changes when it is a curved root and you straighten it. The initial length might be 21. When you straighten the root and then you start with BNP, it might be 19 mm. So then at the end of the treatment, we keep on wondering, why did my working length change? So this is very important and overlooked point about change of working length. So this is mandatory to know. Patency. So as I've mentioned, suppose my working length is 21 mm and I go ahead with my larger number files. I take pro tapers and all the progressive tapers for BMP. If it is a thin, narrow canal, what am I doing is I'm creating a clog. I'm creating a clog apically. So I need to remove this clog. If there is going to be a clog periapically, the drainage is not going to happen. So if my drainage has to be good, there has to be patency. So how do I check for this patency? This patency is done with your 10 number file and only 10 number file, and push it beyond the apex. Now this pushing beyond the apex happens at the minor diameter of the root. We have minor diameter and we have the major diameter. Major diameter is something which is seen in a radiograph. Minor diameter is the dentinocemental junction. So my file is going to go beyond this minor diameter of the root, which is going to create the patency and the drainage of the periapical area. If I'm not going to give a good patency, I'm going to create a clog. It is as good as giving a short root canal filling. So I would like to share this one very good case which was referred to us. The root canal really looks very good. The root canal is good with good filling and good lateral condensation, good seal, everything. But the patient still had pain. Now, what was the reason? The only reason was this area where there was no patency. This was the only reason we had to do a re-RC. So what we did was we created a passage and then we sealed the canal. Another very interesting case which very recently came to our clinic was this case. Now, can you just see, just give me a moment. Huh? Yeah, sorry. So this another case was with long slender roots. A root canal was attempted, a root canal was done, it was obturated, a post-op filling was done. The patient was just about to go for a crown. And then the patient developed this kind of a swelling. Now after this swelling was increased, she went back to the dentist. She was given antibiotics, augmentin and what all. And this swelling increased and increased. And finally, when she came to us after a gap of say around 10 days, it was so bad. She continuously had pain. She had taken painkillers and what all. So we had to start with her re-RC. We also had to give her extraoral incision because only RC was not going to help her to drain the pus because it was already tender and there was so much of a swelling over here. So we gave an incision from here and it oozed out like a waterfall. You won't believe me. It literally oozed out like a waterfall. The patient immediately had relief after we drained it. We gave dressing for the next 1 week and then follow up and dressing for the next 10 days. And then we obturated once the canals were fine, once there was no oozing seen, once her extraoral lesion was healed, there was no scar, and then the patient was happy. So just one small thing of not taking a good working length can do, absolutely, it can create an havoc. So this is very, very important that we take a good working length. Now, if this dentist would have seen a preoperative radiograph, he would have ideally been in a situation where he would have anticipated that the root was so long. The obturation was just till the middle third. Then a post-op filling as well was done and was about to place a crown. So this is absolutely a wrong way to treat a patient. Then in cases of transportation, now it is very difficult to change the path which has been created. So it is important that you read a radiograph before you start with negotiation of the canal, BMP of the canal, and do not be in a hurry. This is what you end up with. If you force your file, it goes beyond and it might fracture because it gets entangled over here. It separates at this point and you block the apical foramen. Then coming to obturation. Now this is a scenario which is called as overfilling. Now this overfilling is your sealer which is going beyond the apex. This is underfilling where your GP is short, and this is overextension. One sec, sorry. This is overextension, which is again not acceptable. So overfilling, when we say that a small puff has to be seen in the periapical area, that doesn't mean you keep on pushing, you stand and you push the sealer beyond the apex. That is not the way. The periapical puff has to be the outcome of the obturation that you do. You just place the cone, which is just the 0.5 mm short, and you push the sealer, and that sealer has to go only in between your minor diameter and the major diameter of the apical area. So that is where you see a puff. Why you need to get a puff? It is just for your satisfaction and for you to know that you've reached the periapical area. That is it. There is no otherwise significance for this puff to be present. And this is definitely an unneeded thing to happen. When we talk about this, now sometimes most of the dentists, they are happy to see that I've gone till the apical third. No, but my dear, you haven't created a patency over here. The lesion is going to keep on increasing because there is no passage, there is no pathway for the infection to drain through the root canal. So it is as good as you've not done a root canal because the infection is going to keep on piling and either the patient will have to go for a re-RC or for an episectomy. Again, overextension. So overextension is again because of improper working length. So such cases, most of the times the patient, they come in pain because there is over instrumentation. Your hypochlorite has gone beyond the apex, you have perforated the apical foramen, and then you have moreover obturated and sealed the canals. So please do not change the working length. It plays a major role in a good life of a root canal. Then post-endodontic filling. This is very important and most of the times overlooked. Choice of the restorative material, a good ferrule effect, crown to root ratio, post and core, and crown margins. Now, up to you, whichever restorative material you have to use. Now, most of the cases which are referred to me, I do not do a post-operative restoration because I refer the patient back to the dentist who has referred the case. So I do only a root canal. But in some cases wherein I want to have a good seal, my choice of restorative material is amalgam. It can be your composite restoration as well. But I would suggest if you have to go for a composite restoration, always use a contrast color while placing it on the floor. If at all the patient needs to go for a re-RC, we can distinguish by removing the coronal part, which is a tooth color restoration, and a contrast part, which will help us to go towards the orifice and not damage the furcation area. So whenever you have to choose a material, it has to be a contrast material in the chamber. Ferrule effect. Ferrule effect plays a major role. Now, this kind of a leakage is going to spoil a good root canal. So here, can you see a leakage over here? So this, my crown margin has to go beyond this. So this is a 360-degree preparation of the tooth. So whenever I have deep margins, my crown margin has to go below the restorative material. So my tooth margin or my crown margin has to rest on a healthy tooth structure. That is what we call a ferrule. Again, coming to crown margins, see now, here the crown margin should have been somewhere here. Here the crown margin, after the leakage, after maybe few years, what happens is, even though the root canal is fine, my root has started to get destroyed from this surface. So my neck of my tooth, if it is going to get destroyed, it is not going to take the load of the coronal area. Same with this, though my crown margin tried to go till here, there is still some leakage over here. So the ideal mode of treatment has to be removal of the crown, replacement of the filling, and replacement of the crown, giving a good ferrule effect from here. Then coming to crown to root ratio. What is crown to root ratio? How much should it be? Ideally, it should be 1:2. So the crown has to be 1 and the root has to be 2, because my anchorage is going to be from the root. At the most, it can be 1:1. But if it is less than that, then you should not think of going ahead with saving that particular tooth. So the crown to root ratio is the ratio of the length of the part of a tooth that appears above the alveolar bone versus what lies below it. It is an important consideration in the diagnosis, treatment planning, and restoration of teeth. One that hopefully guides the plan of treatment to the proper end result. Now, in this case, you can see that here it is just almost 1:1. So this is okay, still acceptable, but my anchorage is definitely compromised. So if at all anybody plans to go for a bridge by straightening up this tooth is definitely not the one which should give support for a 3-unit bridge. Then I need to take the support of the adjacent one as well. If we can compare the bone support, which is for this premolar and second premolar, we can make out the difference of the bone loss. So my crown to root ratio should not be compromised, as the inflammation associated with the periapical area causes bone resorption and disappears, revealing more of the root structure. So my effective crown height in relation to the effective root height is going to change, and the prognosis is going to be from favorable to unfavorable. So here, because of periodontal problem, my bone has resorbed and it has exposed the root. So my crown to root ratio has drastically changed from say around 3:1, I would say. So this is definitely not recommended to put a load on this and to give a bridge over this. Then post and core. So I am personally fond of eye posts. The reason behind that is I get a good what you can say adaptation of the eye post in the cervical region. Now this eye posts, they match with the size of the piezo. So I remove the 2/3 of the material, my gata parcha. I use a 1 number piezo. I go till the desired length. I use a 2 number piezo. I go till the desired length. And then I take the length, or I see how my piezo, my eye post is fitting. If this contour or this flare of my eye post is somewhere here, then it is going to dangle in the canal. So with other posts that we place, even if it is dangling in the canal, just remember how you've placed the posts earlier. So even if it is dangling in the canal, what we do is we cement it. So the strength of the post is coming from where? It is coming through the cement. So I do not want that strength to come from the cement, because with the occlusal load, with the masticatory load, my cement might crack. Once my cement starts cracking, the whole of the unit will come out in patient's hand. So if you've seen many of the times, the patient comes to you with a broken tooth as well as a post inside it. So why does that happen? First of all, the fit of the post is not good. You are completely relying on the cement which you've luted with. Secondly is your crown margin, which has not merged. There is no ferrule effect. So all these reasons will cause the popping out of the tooth along with the post and the core. So this taper of my piezo, of my eye post, exactly fits in the taper of my piezo. So the minimal work is done with the cement. The major part is retention of this post is because of this design, which will fit in the coronal third of the tooth. Then coming to differential diagnosis. So whenever the patient comes to you, you have to see where the problem lies. It can be referred pain. It can be a misleading tooth to you. Now, this was the case wherein the patient came to me with pain. So what was the reason? The only reason was a deep gingival pocket. So always evaluate for the third molars. They ideally need to go for extraction. But if the jaw size is been made for this third molar, then you also need to evaluate the upper third molar. So most of the times, these upper third molars, they push the food particles, or every time the patient masticates, it causes inflammation of this area. So the only thing that we did was to curate this area with deep scaling. The patient was informed to go for extraction, but the immediate treatment was curettage of that particular tooth. Same with such cases wherein there is food lodgement, it causes pain. So what happens at a first glance, we say this has to go for root canal, but the problem is lying somewhere here. So if we do not solve this problem, if we do not tackle this problem, this root canal is not going to help to relieve the pain of the patient. Similarly, here we see a very deep filling, but the problem is lying here. So a differential diagnosis plays a major role. Now here the patient had come with pain in his lower teeth. Occlusally, if we see, the tooth structure is intact. There is no destruction of the tooth structure. But on a radiograph, it shows that the whole of the furcation is compromised. The roots are compromised. So these cases, they need to go for extraction. Same with this case. The furcation has been compromised. How can anybody expect for this tooth to take the load of mastication? It cannot take the load of mastication. MTA, it is a miracle material, but it has its own limitations. It cannot reinforce the whole of the tooth structure to take the load of mastication. So this portion, which was completely destroyed, maybe during obturation or during access opening, was a completely compromised tooth. Maybe this would have gone for hemisection or bicuspidization. So when to do a RERC or when to go ahead and when not to. In such cases, I do not see a canal over here, but what I can see is a lesion over here. What I can see is the changed path of access opening. So such cases, I have to tackle such cases because I cannot leave it the way it is, even if it is a calcified canal. Similarly, if I have to read this radiograph, I can again see a calcified canal over here, but at the same time, I cannot see a lesion over here. So if the patient comes to you with a complaint of discolored tooth, we can just give a laminate in such cases rather than going inside, digging the tooth, changing the path of access opening, perforating the root. It doesn't make sense. We are compromising the life of the tooth. So we need to know when to go ahead and when not to go ahead with RC. So always take a preoperative radiograph, read the radiograph, and then go ahead with the treatment plan. So this was one very interesting case. This, in fact, we had done when I was doing PT. There was internal resorption. There was an attempted access opening, which was done. Here, there was a calcified canal. So that time we didn't have microscope in our college. So we tried to negotiate with slow filing. We reached the apex, but something had to be done. So my purpose of telling you all this, in such cases, we have to do something because this lesion will keep on increasing. The tooth can fracture from here. So we had to do a good cleaning and shaping, and with core carrier. So at that time we had used a core carrier with lateral condensation, and this internal resorption bulb had got filled. So this outcome was really good and we could save this tooth. Similarly, this case which I showed you earlier, so what we did was we tried to save this tooth and we tried to push some amalgam from here, and it actually reinforced the tooth. The patient is still fine. We take a follow-up X-ray every 6 monthly or yearly. So this, in such cases where I mentioned earlier that there is transportation or the path of the file has changed, it is very difficult to come back to the normal canal. So it is as good as you treat this kind of a transportation as another apical opening, if you can say. So such cases, if you end up in drilling more and more, you compromise the what you can say, the strength of the root. You might compromise the dentine and the cementum of the root, and it might end up in root fracture. So leave it, wait and watch, and treat rest of the things. This can be taken care of. If at all, after a follow-up, if you see a lesion developing in this area, then you can again think of doing a surgery. But otherwise, do not intervene in such cases. Another way of doing a differential diagnosis is through a sinus tract tracing. So sinus tract tracing is normally done with a gutta percha. Normally we prefer to use 4% S2 cones because then they are sturdy and exactly go through the path. Using 20 number 2% cones, they normally bend. If at all there is some resistance, they bend in the canal and they do not exactly reach at the point where the sinus tract has started. So here we have traced the sinus tract, and that has helped us. Again, this was one case which was re-RC, and the post is acting as a restorative material in the root, and there was nothing in the periapical area. A very sad scenario. So we had to remove the post and enlarge and then trace the sinus. Now, surprisingly, this GP point was going towards the adjacent tooth. It was not going towards the central. So again, it indicates that the adjacent one also needs to be RC treated, because otherwise your healing of the canal or healing of the lesion is not going to happen. If my lesion is touching the adjacent tooth, the pulp most of the times has become non-vital. So I need to treat the adjacent one as well to stop the oozing of the lesion. This was one case with internal resorption. a very long-standing infection, say 2 years and 3 years, the tooth was left open unattended due to COVID. So there was internal resorption, and then there was a sinus which was present buccally. There was a sinus present palatally. For say around 3 to 4 sittings, the sinus just didn't disappear. So then finally we decided to go ahead with obturation. And what we did was, using a bioceramic sealer, we did the obturation, and after a week's time, the sinus had disappeared. So sometimes it is said that we can use bioceramic sealers, or in the presence of sinus, sometimes if the cleaning and shaping is good, we can go ahead with obturation and the sinus heals. So when such cases comes to us, or when such cases happen in our clinical practice, what and where did it go wrong? We keep on wondering what went wrong with this. So just to summarize what we have seen up till now, to read the tooth, to take a good IOPA, and to read an IOPA, see what it wants to tell you. Open the coronal part. Don't be in a hurry to reach the periapical region. Use 10 number files for establishing glide path. Check for a king and go step by step. Now you should also know when to stop. This is very, very important, that you should know when to stop. Do not go ahead when cases have already got screwed up. Now, this was the case which I showed you earlier in regards to axis opening. So when this case came to us, this axis opening was fine, and this was compromised. So we slightly tried to straighten the wall from here, and under the microscope, we tried to retrieve this. Now, unfortunately, what happened is I too separated one more file. So there were 3 files in this mesial canal, which complicated the case even more. So ideally, we should know where to stop. Finally, we removed all the 3 files, but then we ended up in perforating it laterally. But under the microscope, we could place MTA in this area, and then we could finish and obturate. But things will not work out if they are not done under the microscope. So if we do not have a microscope, do not go ahead with re-RC of such cases, or with loops try to retrieve the instruments, because your ultrasonic will keep on digging in all over the dentine, and it will thin out the root, and it will finally cause perforation of the root. Similarly, in such cases, if you know that there is no point negotiating or retrieving the instruments which have got stuck inside the dentine or in between the isthmus of the 2 canals, then the cases, they get really difficult. So we need to know where to stop for such cases. Same with this, as I showed you this one earlier, on negotiating or on evaluating this furcation area, we decided that this shouldn't go for re-RC. So not every case, you are not a Superman to save each and every tooth. There are limitations with the tooth, with you, with the material and everything. Now, when cases come to us with silver points, such cases, it is very, very difficult to remove these silver points. The silver point can only be removed when it is above the orifice. So by God's grace, if you get a case wherein you can see the end of the silver point above the orifice, you can hold it with fine tweezer and you can pull it out. But in such cases where it is in between the middle third or the apical third, it is absolutely very difficult to remove such silver points. The only thing that you're left out is to dig with your ultrasonic and dissolve or break that silver points into, or crush that silver point and then irrigate it and remove. But it is very difficult to do this. So what we had done was to split the root, do a hemisection, remove that particular root. So my whole point of telling you all this is, do not force yourself where it is not possible. try and understand that this case has to be evaluated in some other way. Not every case. Here it is difficult to bypass as well because the silver points are very big in diameter. So it is difficult to bypass. In the bargain of bypassing, you might just end up coming out through the lateral surface of the root or through the danger zone of the root. So then you are spoiling the case even more than what it was before. So always evaluate what kind of a treatment is needed in such cases. How good is your eyesight? Now, slightly coming to the magnification part of this, I'm not going to go into the details of microscope. You're already running late. So how good is your eyesight? I would say you try and see if you can focus on the picture which has been given adjacent to this. Slightly close your eyes and maybe you will be able to appreciate the picture better. Same with this. Can you read this? This is no sex causes bad eyes. Okay, so I cannot see this. I have to close my eyes a bit. Try and close your eyes a bit, and then you'll be able to read it. Same with this. Do not strain your eyes. You will not be able to see anything below that. So, what we need in our clinical practice is magnification. I started my clinical practice, say, around 15 years back. And for the first, say, 7 to 8 years, I did not have a microscope. But then I started getting cases which were referred to me for, say, separation of the canal, finding the missed out canal. And then there, at that point, somewhere I thought that I need to upgrade my practice. And then I opted for Zeiss Opti microscope. So that has absolutely changed my way to look out towards a root canal. It has completely changed my clinical practice. So how do we go about? Where do we go ahead with a microscope and where we can go ahead without a microscope? So how do we go about with a microscope? So these are the cases wherein there is a fracture of a instrument which is in the middle third. So in such cases, I have many colleagues here who try doing this kind of a case to retrieve with loops. My dear friends, it is very difficult to see with loops beyond the middle third. If it is at the cervical third, I would still ask you to go ahead with it. But beyond the cervical third, beyond the middle third, it is impossible to go ahead for retrievals with without a microscope. So this was done under the microscope. Most of the cases which I get, most of the times the dentists, they tell us that you just retrieve the instrument and send us back to us. So that is what we had done here. So we just retrieved the instrument and the patient was referred back to the dentist. Here again, in the middle third, this instrument was removed under the microscope and a good obturation was done. The patient is very happy. The dentist who had referred is also very happy. Again, the apical third instruments, yeah, they are not made up for removing without the microscope. At the most, what we can do is try and bypass, but do not try to remove it with ultrasonics if you do not have a microscope. So something that can be done without a microscope is wherein we can try and bypass instruments. So where we get a catch, when there is a separated instrument, we need to take our 10 number file and see if we can tap and get a catch around this file. So if at all we get a catch, initially my 10 number will go, say, around 2 mm. Then I go back, I take my 15 number, I go 1 mm. I take my 10 number, I go 5 mm. I take my 15 number, I go 2 mm. Slowly what I'm trying to do is I'm creating a path around this file and trying to bypass this file. So here, we did not bother to remove this file because this bypassed through this canal and we could obturate it. Because earlier, the case when it was referred to us, the earlier dentist had tried to remove it with loops. So that was the reason this amount of tooth structure was already destroyed. So we didn't want to destroy it more or perforate it laterally. And since it got bypassed, we did not bother to remove the file. We placed it inside and we did an obturation. Again, this file, the first X-ray, when I showed you this of overfilling, there was a file separated inside, but we could manage to bypass it and we obturated, and then the sealer also resorbed eventually along with the lesion. When we force our file, what happens is we create a ledge. So if I do not pre-curve my file and if I force my first file itself, we keep on wondering that how can a 10-number file create a ledge? But yes, my dear friends, it can always create a ledge because I haven't followed the path of the root or followed the path of the canal. So whenever I read a radiograph, I pre-curve my instrument, I pre-curve my 10-number file, I go 10 mm, I come back, I take 15 number, I go 5 mm. So why am I trying to repeat this same thing again and again? Because this is very important for your 10-number file to slowly reach the apex without creating a clog or without creating a ledge in the canal. Now here, the canal was not negotiated. The ledge was formed here itself. There was a ledge here. The ledge was formed here. The ledge was formed here. The ledge was formed here because here the curvature of the canal was not followed. These kind of things are clogs. So if the patency is not kept, or if we do not follow the patency rule, we end up in short restorations or short obturations, which lesions in the patient's mouth. So just to summarize, missed canal should be evaluated. Anatomic variations are read morphologically and clinically. Perforations to be taken care of in the coronal third, middle third, apical third. Cleaning, shaping, and irrigation is very, very important. Ledge, it's formed by us. So iatrogenic ledge formation is not acceptable. Transportation and separation is again iatrogenic. So if we follow a step-by-step rule, if we do a good access opening, good orifice opening, crown down procedures, then we can avoid all of these things. Apical extrusion of debris and apical perforation can be because of improper working length. Apical dentinal clog is because of improper patency. So all these things that we have seen up till now, I'm just trying to summarize. Post-op fillings, always go for contrast fillings. So that will help you in re-root canals. Coronal leakage, see to it. Always whenever we give a crown, what I do is I call for a metal trial and I take the metal trial and I take a radiograph. So with that metal trial, I can see if my trial is merging with the tooth structure. If at all it is short at that particular time, I ask the lab guy to repeat the case, because once the porcelain comes or once the PFM comes, then it costs double for the lab guy as well as for you. So at the early stage, when you get a metal trial, always place the metal trial and take a radiograph. That will help you to see if there is any coronal leakage or how the merge of the crown or the fit of the crown is. Then root caries, again, root caries need to be evaluated. Also the crown root ratio. Ferrule effect, I've already mentioned about this, and I'm again stressing that a radiograph is mandatory. So why not save a part of our body which the God has given us? Don't lose hope. One last case that I would like to share with you all is, this was the case which came to us last 10 days back. So this girl, this was a girl patient, and she had this zirconia crown placed here, and she herself is a dentist. So she had visited many dentists, and everybody had asked her to go for surgery and episectomy because the canal is the exaggeration of blunderbuss, I would say. The walls are like almost parallel to each other. There was one dangling GP point like a noodle inside the canal. So this RC, apparently this was the obturation which was done when she was doing her PG from one of the colleges, and this was how it was left out. So this patient, she came to me because she had sinus. There was a huge abscess over this lateral incisor. So under the microscope, we tried to remove this particular GP point. But this particular point was stuck on the walls, and here there was all over, there was the periapical tissue which had grown inside the canal. So there was continuous oozing and pus discharge and bleeding, because of which the site was not at all clear, and we could not leave this, we could not remove this GP point. So what we did was we left it where it was, and I told the dentist that we'll go ahead with placing of MTA in this area. Let the GP point be as it is. We placed MTA while it was while it was oozing, or while it was bleeding from that area. We placed MTA, and after 2 to 3 days, we did a backfill. And miraculously, you won't believe, I could not put the what you can say, the clinical picture, because it was in another phone of mine. Miraculously, her first day when we placed MTA, there was a huge sinus. We went ahead with it. After 6 days, the sinus had shrunken. It didn't go away. It had shrunken. And after 10 days, when I called her for a follow-up, the sinus had completely vanished. So my dear friends, do not lose hope, but do not do acrobats. Decide where and what things need to be done. Have an enjoyable endodontic journey. Thank you very much for your time, for peacefully listening to me, and thank you very much.
Thank you so much, ma'am.
Thank you.
Can we proceed for the question answer session, ma'am?
Yeah, if everybody is not late, because it's 9:15, so whatever you say.
Okay, ma'am. We'll try to select a few questions relevant to the topic, and
Sure.
we'll try to answer the remaining questions at any social media platform.
No problem. No problem.
So
Now, should I stop sharing?
it's up to you, ma'am. It's not an issue at all.
No, if anybody wants to talk about the slides which I have shown, I can show them. Not a problem.
Okay, ma'am.
Yeah.
So I think we have one question, ma'am. Yeah. So we have a question. What percentage is safe to use sodium hypochlorite?
Sodium hypochlorite, I normally use 5%, because heat treated or lukewarm sodium hypochlorite has got great efficacy to dissolve the pulpal tissue. But again, as I said, that any amount of hypochlorite, if it goes beyond, it can cause burning of the periapical tissue. It should not ooze out from the coronal area. So pre-endodontic buildup is mandatory. Then do not force the hypochlorite in the canal, or do not what I can say, engage the syringe in the orifice, because that will push the hypochlorite solution beyond the apex. So I am more comfortable with using 5% of Circamed hypochlorite, which really gives nice results.
Okay, ma'am. Are heat activated files and heat treated files the same?
Yeah, heat activated files and heat treated are normally the same, because they come back to the shape once they have been inserted in the canal. So all the files which come into the market, which are heat treated or heat interacted, they are safe to use, and they have good flexibility. So more number of canals and teeth can be treated with them.
Okay.
I can read somewhere like 8 number file can be pre-curved instead of 10 number.
Yes, ma'am.
Yeah. So, see, normally what happens now, 8 number is very flexible, I would say. 10 number will exactly follow the path. You can use 8 number, but most of the times, even if there is a small block, what happens is your 8 number gets kinked. It gets bent. So once you remove it, it has gone for a toss. Instead of that, if we use a 10 number, it is sturdier and it will guide you along the pulpal chamber. Secondly, if at all it is a very thin canal or very much calcified, as I mentioned earlier, go step by step. Use a 10 number, go back to 15, go back to 10, go back to 15. That will create a path for your 10 number file.
Okay, so the next question is, ma'am, in some cases, 10K file won't go and reach apex, even if we pre-curve. So what can be the reason and what should we do?
So that means that there is a ledge formation or there is a dentinal clog. So as I mentioned earlier, firstly, when you place your 10 number file, if we go at a point where there is a curvature, or even if you pre-curve it, if the dentinal clog gets pushed in that curvature area, then second time when you use your 10 number file, it is not going to go. So what you need to do is your hypochlorite also needs to reach in that area for flushing of any of the debris. So you take your 10 number, you go to 15, you go to 10, you go to 15. So what you're creating, you are opening the size of the pipe. See, it is somewhat like a pipe. At the end of the pipe, there is all kichad, there is all drainage. So you have to reach till the end of the pipe for allowing the drainage to come out through the pipe. So if I clog the pipe somewhere in between, there is no passage for my drainage to come. So always go step by step with 10, 15, 20, 10, 15, 20. Do not force your file to reach the apex. May it be your 10 number or your 8 number file.
Okay, ma'am. So what is your thoughts on using reamers rather than using K files?
Oh, I'm actually not very for reamers or even for edge files because they bind in the canal. Okay, so the K file is always safe to use because it will not bind or it will not engage in the dentine. Your edge file will engage in the dentine. Most of the times I have seen even the students in our college, they put one K number file and one H number file to take a radiograph to see which file has gone in which canal. But no, my dear friends, we have different techniques. We have K files which are efficient enough to go in the canal and negotiate the canal. There is ideally no need of reamers and H files.
Okay, ma'am. What should we do if apical third is calcified?
See, normally the calcification that happens, it starts from the coronal area. Okay, so when we give an excuse that my apical third has not got negotiated and it is calcified, that is not the scenario. So what has happened is you've created a clog. It is not the calcification. Calcification always starts from the chamber of the root. So if it is calcified, that you are going to feel that stop right from the coronal region. So once you've gone through the coronal, through the middle third, and then apical, if you are giving a reason that it is calcified, that is the reason my apical file is not reaching the apex, then it is the clog which has happened or it is the ledge which has happened. It is not the calcification.
Okay, ma'am. Okay, we'll try to answer just few more questions only, then we'll try to end this discussion. Okay, ma'am?
Yes.
Okay. So can we do a single sitting RCT in a tooth with a slight periapical infection?
I wouldn't suggest for that. See, whenever we do or open the root canal, I feel that we should always give a second chance for ourselves also to have a fresh look at the case. When we start with a root canal, now, see, if at all the patient has to fly abroad or if he's in a hurry, then it's okay. Or if you go for a consultation. But again, for consultation, I would say most of the patients, they come back to the consultant. Even I used to do consulting. They come back to the dentist, the original dentist, saying there was pain. So the whole reason behind that is doing a single sitting wherein we do so many procedures in say 40 minutes to 1 hour. So why not give a second chance for ourselves and the tooth, allow it to drain, allow it to heal, and then do an obturation. So I'm not very for single sitting.
Okay, ma'am. Is it a composite better than amalgam for coronal seal? As we know,
Yeah,
yes,
this is a very debatable topic, I would say. So while showing my slides also, as I said, that we can definitely go ahead with composite, but the only thing is we have to go ahead with the contrast material. It will definitely give you a good seal, but in some cases which I showed you, it is next to impossible. The coronal perfo which I showed you, which was from the lateral side, it is next to impossible to push composite or any kind of material because of oozing out from that area. So such cases, my amalgam is going to make wonders over there because it is going to slightly expand because of the moisture there is secondary expansion. So it is going to give me a better seal. So I feel there shouldn't be any written rule that this case I have to do a composite, this case I have to do an amalgam. So according to the case that you've selected, according to the good prognosis, you should be selecting the post-op filling.
Okay, ma'am. Any specific instruments for removing the pulse stones?
See, first of all, you need to identify that there is a pulp stone. So if you see a radiograph, you see radio opacity in the chamber. In cases where you see radiolucency, it means that there is no pulpal stone or no stone in the chamber. So if at all you see radio opacity in the chamber, what you need to do is you take your ultrasonic and go around the stone. Okay, so what happens is that disengages the stone from the dentine, and then you can see and remove it with your DG16. Sometimes what happens is this stone is attached to the furcation. So such cases, again, don't be just behind removing the stone, because then you'll perforate the perforation area. So you need to evaluate by seeing a radiograph. Clinically, when you see, you always see a white milkish color of a pulpal stone. So that will differentiate from the dentine color and enamel color, which is white and yellowish, and this is milky white. So that would be your pulpal stone, which you need to disengage from the what you can say, from the pulpal floor by removing the dentine with your ultrasonic and going around the circumference of the pulpal stone. So that will disengage and remove the stone.
So we'll try to end up with the last question, ma'am. How do you select the root canal sealer for a particular case?
See, now root canal sealer, I'm normally comfortable with H+ or any kind of a resin sealer. Zinc oxide eugenol is no more used as a sealer because periapically it gets dissolved. So once it gets dissolved, what happens is there is a seepage or passage of or leakage through the periapical area. So we do not get a good seal with zinc oxide sealers. The newer sealers like bioceramic sealers and all are very good because they mimic the dentine and they seal. The sealing ability is very good. Nowadays we get MTA sealers as well. So MTA sealers are normally used in lateral perforations, wherein the your MTA, the regular MTA, will not get pushed into that lateral perforation. So resin sealers, I would definitely recommend resin and bioceramic sealers.
Okay, ma'am. I think we have come to the end of this discussion, and thank you so much, ma'am, for sharing your knowledge and expertise when it comes towards managing the endodontic failures.
Thank you so much.
Definitely, many of us will leave this discussion with amazing takeaway points and implement techniques as per discussed.
Thank you
So
so
thanks
much.
to all the doctors who had participated for this webinar, and I hope all of you will depart this session with positive, confident manner.
So I hope it was useful and it will help you in your day-to-day practice from tomorrow itself.
Definitely, ma'am. Definitely.
Because everything, most of it was practical, what we've faced for the past 15 years, what we've gone through, and through the referred cases that we get in our clinical practice. So I had compiled all the clinical cases for actually for the clinicians, I would say.
Yes, ma'am. Definitely, ma'am. So to know more about our upcoming webinars and workshops, you can visit our Instagram or our Facebook page, and we do have our YouTube channels. So to check our previous webinar recordings. So again, ma'am, thank you so much for this wonderful presentation, and I would appreciate your valuable time for this contribution, ma'am. Thank
you so much. Thank you. Where can I get the recording you said? Sorry.
Definitely, ma'am. We'll be trying to upload this in the YouTube channel.
Acha. Okay, fine.
Okay, ma'am. Thank you so much and have a great night.
Thank you so much. Thank you, everyone.